We're going to go ahead and get started. So welcome. I wanted to welcome everyone to tonight's webinar. I'm your host and moderator, Lauren Levine. We've got a great topic and a great speaker. I'm so happy to have Dr. Nazarian back. I'm going to give him an intro in a minute or so. We had a lot of people registered for the webinar. We typically get somewhere between 500 to 1,500 people, and this was another great turnout, and we appreciate all of you for joining us this evening. I'm only going to speak for a couple of minutes. I want to make sure that Dr. Nazarian can speak for as long as he needs. We also want to make sure that we leave time for questions. Any of you who have been on these webinars know that we typically have way more questions than we have time to answer them. We're going to stick to a 90-minute time frame here tonight. So we'll try our best to get as many as possible. If we don't get to yours, I apologize. But as I said, normally we have well over 100 questions, and there's just not much time, enough time to do that. For those of you who haven't been on a webinar in the past, it's pretty easy. You have a little control panel on your screen. You just go ahead and type in your question as you think about it. And as I said, we're going to try to get to those before we're done this evening. In the next couple of days, you are going to receive a few things. This webinar, like all webinars, is being recorded. You'll get an email sent out to you sometime in the next couple of days where you can download and watch the recording at your convenience. So don't worry if something happens, you can't stay till the end. Not a big deal. As I said, we're recording the audio and the video, so you'll be able to review the whole thing at your convenience. We want to thank our sponsor tonight, which is GoldenDent. I've done dozens of webinars with them. I mentioned that we usually get 500 to 1,500 people. That's about 5 times what I normally get from my own webinars. They always have the best content, the best speakers. So I just want to thank them for their ongoing sponsorship. We've done a lot with them. We hope we're going to continue to do a lot more with them. They are 100% committed to dental education. Towards the end of the presentation, Kurt Lawler from GoldenDent will come on. He's going to speak for a couple of minutes. He normally has some type of fantastic special pricing and some educational opportunities. Also, if you are here live, then you will be getting a CE certificate. GoldenDent's going to be handling those. When we have hundreds and hundreds and hundreds of people on the webinar, it takes a while for those to go out. So please be patient. Oftentimes it can take a few weeks, but we will make sure that everyone that's on live gets a copy of that. So without further ado, I wanted to introduce our special speaker for this evening, and that's Dr. Nazarian. Dr. Nazarian maintains a private practice in Troy, Michigan, with an emphasis on comprehensive and restorative care. He's a diplomat of the ICOI, which is the International Congress of Oral Implantologists. His articles have been published pretty much everywhere, in a lot of the popular dental publications. He's consistently listed as a top dental educator. He's conducted many, many lectures, hands-on workshops on aesthetic materials and dental implants throughout the US, Europe, Asia. He's faculty for Amplified Dental Training, which teaches atraumatic extractions, grafting, and immediate dentures. And he also founded the Ascend Dental Academy, which teaches all aspects of dental implants. So with that, Ara, we're looking forward to tonight's presentation. Take it away.
Great. Thank you so much, Dr. Levine, and welcome, everyone. Today's presentation, we're going to be talking about making composite restorations stronger with zirconia, and we'll also talk about some combination cases where we do some crown and bridge, as well as some extractions, grafting, and implants. Well, when we look at the definition of a composite is essentially a highly cross-link polymeric material that's reinforced by a dispersion of amorphous silica, glass, crystalline, and now obviously we are adding zirconia as well, to an organic filled resin or short fibers to the matrix by a coupling agent. If we look at a definition of a composite outside of dentistry, so if we're looking at it in materials aspect or science, the word composite essentially refers to a solid formed from 2 or more distinct phases that have been combined to produce properties superior to or intermediate to those of the individual constituents. So if we really think about this type of thing, what we see is that the components of a composite are a resin matrix, some type of filler material, and in order to connect these resin matrices with a filler, we need some type of a coupling agent that that allows you to combine the two. We also have initiators, and these initiators are usually photo initiators. So we cure or use our curing light to activate these initiators. And then when we're looking at a depth of cure, we also have accelerators. So if you zap the top part of the composite, then these accelerators will allow the material at the bottom portion of the preparation to cure. And then obviously we're going to add pigments to add the colors of the different materials. In order to understand the infusion of zirconia particles, we first want to talk a little bit about the filling materials and their sizes. So based on what Bain and Heyman came up with, filler particle size and distribution can be characterized by the different variations in sizes. So if we look at mega-filled composites, we see very large fillers, and we saw this in the 70s. These were composites that did not polish very well. They were strong, but you would see the seams open up because there wasn't a smaller material or filling material that was in them. We look at macro-filled composites, and that is where we're looking at 10 to 100 micrometers. Mid-filled composites, we're looking at 1 to 10. Mini-filled, we're starting to get smaller and smaller. And then obviously, in today's day and age, we're looking at some nano-filled composites where we're talking very, very small particle size. If we look at the schematic, we can see what the macro-filled look like. So imagine that the yellow or tan background is the resin matrix, and in the macro-fill, you see the white particles at the top left. And so what happens over time is the resin wears out, and then you have these large particles. And since you have no smaller particles, what we found with these earlier composites were after time the resin would wear out, you would see these large particles and they would stain. And so that composite restoration was never really polished very well. And over time, you would see it was very porous. Well, later on, probably the late 80s and early 90s, we saw microfills. And microfills were great because they had small particles, and these things polished very, very well. Great examples of this was, let's say, from Cosmodent, we had Renamel. And so in the anterior portion of the mouth, we would use these microfills because they would blend in and you could polish them. They didn't have huge particles, so they didn't have a lot of strength, but they were polishable, and so they would shine very nice and keep their luster. But if you were to put a microfill in the posterior portion of the mouth, you quickly found out that these would wear out very quickly. Later on, in the mid to late 90s, we saw that there were hybrid composites. And the hybrid composites were essentially taking a macrofill and a microfill and combining the two. So imagine a container that not only had large particle sizes, but also small particle sizes mixed with them within a resin matrix. Now you had sort of the best of both worlds. You had strength because of the larger particles, and you had great polishability because of the smaller particles. Well, as we progressed, we eventually saw nanofill composites. Nanofill composites were very, very tiny particles that were compacted together to not only maintain luster and shine and have great aesthetics, but also have some strength. Well, we saw that that works very well. However, when packing or filling this material into a cavity preparation, you found that the consistency was more of like a butter consistency. It didn't fill like a macro fill, or it didn't fill like a composite. And because of that, we found that there were mini fills and midi fills. And so what they did essentially is take a hybrid and mix smaller particles with that and some larger particles with it to really come up with a more compact fill. And depending on where you're using it in the mouth, If it was in the posterior portion of the mouth, we wanted to try and maintain the larger size for strength. And if it was in the anterior portion of the mouth, then there were smaller particles to be able to maintain luster and shine. Well, macrofills came in a variety of different shapes. You either had spherical, which are all round particles, and then you also had irregular shapes, as you can see from the schematic in the top right. In the microfill, we find that there's homogeneous, so they're all similar and alike. And then you also have heterogeneous, which you have a variety of different shapes and sizes mixed together within that microfilled designation. Excuse me. In the midfill and the minifill, we see that these materials have several more particles so that you're able to compact them, especially when we're looking at in the posterior section of the mouth. And then obviously we have the nano-filled composites, which are very tiny. They're somewhat compact, but the smaller particles allow this linking of all the materials with the resin to come up with sort of a universal type of composite. Well, so what do we choose when we're looking at composites? If we look at the three designations of the different types of fill, you have an ultra low fill, you have a low fill, and then you have a compact. According to these designations, an ultra low fill is a composite material that has less than 50% filler material. So if you look at the image at the left of the screen, you notice that you have not a lot of particles, and it could be a variety of different sizes, but there's definitely more resin than you see particles, or at least 50-50. When we look at the middle picture of a low fill composite, those composites are those that are filled between 50 and 74%. You see that it's definitely much more filled than the ultra low, but it's not as filled as what we would see with more of a compact type of composite. A compact type of composite, we see there's a lot more filling material, whether there's silicate, glass, or zirconia particles within this resin matrix. The way that I explain it, which is probably the simplest way to remember this, is imagine a bucket, and in that bucket you place rocks. And in the same bucket, you also place marbles, and then you also place pellets, and then at the very end, you add sand. What you find is a bucket that has a variety of different sizes and shapes, and this allows you to compact this type of material within an area and maintain the luster and the shine of the material. So what we'll be looking at tonight is a material that's a hybrid, but it also has an infusion of zirconia particles. And what we've seen is that the dental trend has already moved to zirconia when we look at indirect restorations, whether they're inlays or onlays or full crown or bridge restorations. If you talk to any dental lab, you'll see that their porcelain fused to restorations has significantly decreased in number over the years. People have been moving more and more towards zirconia. And so this evening, I'll talk to you about a new material that's been out. I've been fortunate to have been using it over 2 years now as a beta tester. And this stuff not only maintains its strength, there's very low shrinkage, and it maintains its luster and shine as well. The last thing we want to see in a hygiene recall patient when we go into the operatory to do that hygiene check is a composite that's worn out like butter, or a composite where the margins are not adapted very well to the tooth structure, or a composite that has just broken because it's not strong enough to maintain some of the occlusal forces. So these are the types of images that we don't want to see when our patients come back within our practices. So let's take a look at some routine dentistry that we do every day within our practice using this new material called Wagofill. And Wagofill is a microhybrid type of composite that is infused not only with silica, but also with zirconia particles. And what these zirconia particles allow you to get is more strength. So this is a composite that's mainly geared towards the posterior portion of the mouth because of the high strength that it has. So when we take a look at this restorations, what do we see? Well, we see that there's some force on these amalgam restorations. They've been polished because of the occlusal forces. We definitely see some margins that are starting to open up and possibly get recurrent decay. So we want to explore around these restorations. And then most importantly, they're unaesthetic. A lot of patients present to my practice and say, look, I don't like the amalgam restorations. I don't want the mercury in my body. I want these restorations removed. The first thing I'll always do is use my intraoral camera to take a photo and put it on the screen so the patients can see what we see. And the first thing I'll notice is some of the margins that may be open or where I may get a stick underneath these margins. And so it's imperative that we explain to our patients that this margin or the seal is no longer intact. And if food and debris can get in there, or even the bacteria that's within our saliva, the mouth is a warm, moist, dark place, and that's what bacteria loves. So decay can definitely grow underneath these restorations. Well, this DemoDent model, which is a patient education model, is something that I created several years ago, and it allows you to explain to your patient what is going on. So if you look at the middle portion of the DemoDent, you can see where the failing amalgam restoration is. So I'll educate the patient and say, you saw the areas of where we had the seam was no longer intact. These areas, if we look at the cross-sectional area, may be leaking. And if this leakage continues, then there may be decay that may be underneath these restorations. That may explain the sensitivity that you were experiencing. So what we would recommend is removing these restorations, cleaning out any type of decay that may be underneath there, and then finally replacing it with a composite restoration. The DemoDent patient education model that is available through GoldenDent also allows you to illustrate to the patient occlusal and interproximal decay. It allows you to illustrate tartar buildup or recession. It also allows you to show the failing amalgam restoration, not only from the standpoint of the margin breaking down, but on the reverse side where there may be a fracture and a necessity for core and crown restoration. So this is something that helps us illustrate to the patient what's going on. So we removed the amalgam, we've removed any decay that was leaking under there, we extend the margin slightly, and now we're ready to place the composite. So we'll go ahead and etch the tooth. I still like using a 5th generation bonding agent where we're etching and bonding. However, 6th and 7th generation bonding agents work very well. The Wagofill composite material can be used with any type of bonding agent, which is nice. And the different types of techniques of filling these cavities are such. The oblique or incremental filling method was to go ahead and place flowable at the base of the preparation and then incrementally build up the composite to avoid any type of shrinkage that may contract these cusps and cause sensitivity. So if you look, you'll see the first layer in gray would designate the flowable composite, and then we could incrementally build this up by going in an oblique manner so that we wouldn't have shrinkage from one side of the cusp to the other. The traditional filling material or filling style with the new filling materials that are available, like the microhybrids and the nano particle type of composites, is what we call a traditional filling. And that's essentially using some type of flowable composite as designated in the gray with the 1, or even some people are using like a resin modified glass ionomer as a base, and then taking a composite that has photoinitiators where you can cure up to a 4 millimeter depth cure and fill it in a 2-stage method. This is also designated as a shaded technique, where essentially you're just looking at the shade of the enamel, using one shade and placing the flowable and then following it with the composite of choice, usually it being a microhybrid or a nano-filled particle. The monoblock flow technique is something that Dentsply initiated with their material called the SDS SureFill Flow. This is a flowable composite that's filled that can be bulk filled. However, you cannot have that portion just exposed to the occlusion because it will break down. The manufacturer, from what I understand, and I've experienced myself in the past, is to use this SDR SureFill Flow, do a bulk fill, and then the last 1.5 millimeters to 2 millimeters use a regular type of composite. This helps prevent a sensitivity, and it allows you to be a little bit more efficient. Then we also have the bulk fill technique. Kerr had come out with a material several years ago called sonic fill, and this is sonically activated to actually be able to do a bulk fill technique. In other words, you're filling that cavity from top to bottom, or from bottom to top, I should say, with only one material. And because of the sonic activity, it softens that composite and it allows it to adapt and flow into the little areas of the preparation and adapt very nicely. And something new that we also have is a heat activated. And so several composites can be used with heat activation to also do a bulk fill. Usually in my practice, if I'm not using some type of heat activation, I'm usually going with a traditional filling method. And that is using a flowable composite as the base and then following up with something like Wagofill at the top. If we're going to be using heat, then we can actually use the Wagofill as a bulk fill and just use that without any flowable composite. If we're going to try to shape these composites, one thing I found that works very well is to use these compo dots. These compo dots allow you to compress and pack the composite and shape the composite very quickly without having open areas in the margin. And then from there, taking an anatomical carver or composite instrument and shape the composite. Again, within our practices, we want to be not only efficient, but we want to be effective and not having these patients come back with composites that are shaped irregularly, or they're breaking down, or they have margins that may be open. So here you can see very quickly, using this method, we're able to place the Wagofill composites. The Wagofill comes essentially in 3 shades, A1, A2, and B1. Again, this is a posterior composite because of the zirconia particles. It will look slightly opaque. However, because it is in the posterior portion of the mouth, who really cares? Nobody is really doing what we see in the journals where they're doing 4 different layers or colors of composite. I'll do that for a lecture and I'll do that for an article, but within my practice in the real world, I want a composite that I can put in there quickly and efficiently, but also have it effective and something that's not going to wear over time. So once we've done that and shaped it, I'll go ahead and adjust the occlusion with a very fine diamond, starting usually with a red and then finishing off with a yellow. And so here we can see the before and after. Once the patient was anesthetized, essentially these restorations were completed in about 5 to 7 minutes. So let's take a look at a clinical example from diagnosis to placement, because a lot of times I'll get patients who will, or excuse me, dentists who will ask me, Dr. Nazarian, how are you explaining this to patients? How are you getting such a good acceptance rate, whether it's composites or full mouth reconstruction that I've lectured before? So here we see some restorations that are failing. if you look at tooth number 19, not only does it have a glass ionomer in there, you see a little dimple of an amalgam, and then you also see a sealant that is failed, or some of it has come out. Now, these look pretty innocent when you look at them clinically. And when we look at the radiographs, occlusal decay may or may not be caught all the time. However, what you'll see when we open this up is that, in fact, there may be quite a bit of composites that may be leaking there. So one diagnostic feature that I've used in my practice is a diagnostic light from SDI. This is what it looks like, and it allows you to transilluminate the tooth to see if there's recurrent decay, whether it's a virgin tooth or it's a tooth that has an existing restoration that may be a composite or resin modified glass ionomer. It also allows you to see if there is some type of a fracture along an amalgam restoration, or to see if the restorations may be leaking. So what I do is I'll explain to the patient, these areas definitely have decay. Not only has my explorer gotten caught within these areas of decay, however, not only that, we'll explain to them by using the demo dent and illustrate that there's 3 levels in a tooth: the enamel, which is the white layer, the yellow, which is the dentin layer, and the pink, H, which is the nerve. And so as the decay extends and goes into the dentin, you can clearly see how it widens up and gets bigger. So our goal is to stop it before it gets to this nerve. So we explain to them using the demo dent what we need to do. So look, I've only removed the restorations and I started removing any decay. I always will prefer to use cavity detection dye. This one in particular is from Curaray. And you can see here we thought we had all the decay removed, and still there's decay that's remaining underneath, that was underneath this restoration. So if I just go back, this looked fairly innocent, and you can see that there actually is quite a bit of decay underneath that old restoration. A burr that I like to use to remove decay once we've removed the majority of the enamel layer is a Sarah burr. These are zirconia or ceramic burrs from Comet. The nice thing is they don't heat up, and it allows you to take all that dentin or decayed dentin out of the tooth. So you can see we're still proceeding and taking that out. And what I like to do is actually show the patient at this level, hey, look, we thought that this was just innocent little cavities, and in fact, they've gone deeper. Just in case this patient has a little sensitivity for a week or two, we want them to know why, because of the depth of the decay. So here we have Optibond Universal. Optibond Universal can be used as a 5th or 7th generation bonding agent. It works very well. I've used it for many, many years, the whole family line of the Optibond. And so we'll go ahead and place that on. And then if you're going to be using heat, you can go straight to the Wagofill. If you're going to do the traditional method, then you can do it in a 2-step where you place a flowable composite as a base or liner and then place the Wagofill. The nice thing again with Wagofill is it's zirconium infused, about 40%. It's obviously a light cured composite restoration, direct restoration. Most importantly, we all know when we take an X-ray of a zirconia crown, it looks like metal because it's so radiopaque. So the Wagofill is also very radiopaque on an X-ray. So you can clearly see where it is when looking at it radiographically. Again, because of the zirconia, the silica within that resin matrix, it's over 70% filled total. So you have much lower rate of wear, you have increased strength, lower shrinkage, and higher radiopacity. Again, it's only available in 3 shades because for the posterior dentition, you really only need 3 shades to make it work, and those shades are A1, A2, and B1. Again, we have a variety of different filling methods. The 2 methods that I like to use If I'm not using heat, is the traditional filling method where we're using flowable composite as a liner and then following up with the Wago fill. If we're going to be using heat, like the phaser gun, then we'll use the Wago fill as a true bulk fill composite restoration. Well, what does the heat do from the phaser? And this is something available through GoldenDent. You can take advantage of the special that I'm sure Kurt will be going over at the end of the presentation. But the phaser can be used as a true one-step bulk fill by improving the characteristics of just about any composite. The nice thing with the Wago fill is it's very dense. So when you place that without any heat, it almost feels like an amalgam. When using the phaser, it transitions itself to a different type of feel. It doesn't feel like butter, but it definitely is something that's a little easier to place as compared to when it's not heated. What does that mean? Well, it means that the placement is going to be better and the handling will be better because you don't have to use a lot of force to pack it. It's got a lower viscosity, so the flowability is similar to a flowable composite, so it can go into the proximal boxes very well and adapt to the cavity preparation that you've created. Preheating increases the micro hardness of the composite, which is a study that was done in 2008 by Munoz. It's safe, so you don't have to worry about this thing heating up, that it's going to damage pulp tissue. And obviously there's going to be less voids and less micro leakage because it adapts to the cavity preparation much better. So these are some of the highlights of the phaser light. I definitely recommend using it. Here you can see we've packed it. We've used the phaser to heat it, and then we'll take our anatomical condenser and shape this composite. We'll go ahead and adjust the occlusion and polish if necessary. And here you can clearly see the before and after. So if we take a look at the first photo, we see these innocent looking restoration on tooth number 19. And then we see number 18, that looks like it may just have a little composite that maybe it needs only a preventive resin restoration. Once we've opened these preparations up, we can see that there was definitely, in fact, some heavy decay. We clean that out further, dye it, and make sure that we don't leave any decay. So this is just affected dentin, and the studies show that we can leave that because it's not turning color. That's showing heavy decay. And then obviously we see the final Wago fill restorations. Again, this was accomplished in a very short amount of time. So let's take a look at class 2 restorations using the Wago fill composite material and the Wagotrix, which is the sectional matrix system. Upon examination radiographically, we see that we have 2 interproximal cavities on tooth number 4 and tooth number 5. So here we see the Wagotrix system. Not only does it come with the sectional matrix bands, rings, and also wedges. So if we look inside, we see that we have a variety of 3 different sizes of wedges. Small, which is the white, medium, which is yellow, and the large. Notice the design of these wedges. It's curved so that when you put them in between the teeth, we're not puncturing the gingival tissue. And then there's these little ribs here that adapts to the surface of the teeth very nicely and creates a nice seal when using them in conjunction with the matrices and matrix bands. So if we take a look, you see the 3 sizes, and then we see the matrices, which come in a variety of different sizes. We have very small, we have a premolar size, a molar size, and then those cavity preparations that may be deep or subgingival. And then we see the disposable Wagotrix rings. These rings are intended for single use. You get several, as you can see in the pack with these. We have seen some people use them a couple more times or a few more times, but the beauty is they maintain their tightness, which is really, really effective. This close-up picture didn't come out that great, but you can see the curvature and the shape of the ribs that we use. So I actually will use these to even separate or prevent damaging the adjacent teeth. So we open up these teeth and remove all the decay. Here you can see the nice adaptation of the matrices, actually the whole Wagotrix system. So everything is clear. We have a nice seal. And now we can go ahead and etch, use our bonding agent, and in this case, we're going to do a bulk fill for both restorations. So here we are using the phaser gun to heat the composite material. So what I recommend when doing this is you could do it as a one stage like this, but I like to add a little bit first, make sure I have my contact, and then add some more at the top. So I prefer to go with the C method or D method when doing these. It's a matter of preference. I think this method here is taking a lot of time in today's day and age with the materials that we have. I have yet to ever experience the B method. You can see there's multiple layers, or even the E method. So usually C and D are the ways to go. So if you look at the first preparation, we can see we did this as a bulk fill. And later in the presentation, I'll show you how I did it as a two-stage. We see that using the Wagotrix, we have a nice anatomical contour. So I'm just going to finish these off and contour any flash or excess with the OptiDisc from Kerr. These are very nice discs that work very well. And the nice part is this area that snaps on is not metal. So if you touch the tooth, it doesn't leave scratches on that we've experienced with some of the discs before. Notice the composite restorations are all the same color, very radio opaque, thanks to the Wago fill. Well, over the years, I've used a variety of different sectional matrix systems, and you can see here sort of the differences in the different systems over the years. And I remember when we first started with the original ones, we would get some separation of the teeth, but there was really not an easy way to put the wedge into that area. This was a system that was available from overseas. It was a disposable type of system, but there wasn't a V shape to it. So when you try to put a wedge in there, it was very difficult. And as you can see, this sometimes would snap. For many, many years, I used the V3 system from GoldenDent, and it's a great system. However, over time, I found sterilizing this, it sort of lost its strength. And so I would have to go and purchase more over the years, or eventually this sort of coating would deteriorate with repeated sterilization. So my transition to the Wagotrix was really liking the V3 system and then going to something that's disposable. Look, we use a lot of disposable instrument or materials within our practice, paper products. To have something that delivers a perfect contact every time is something I highly recommend. And so notice the bulk here of the design of the Wagotrix, unlike something like this, doesn't break. And so it maintains that tightness, not only if you're going to just use it for the one time, if you want to use it maybe one or two more times, some people have, but it is intended for single use. But I know dentists always try to push the limit. Most importantly, you're going to keep that exceptional strength and you're going to get great separation because you get so many of these in the kit and they're very inexpensive. Notice the wedge creates a nice seal, and then obviously we have the matrices. Here you can see I'm putting quite a bit of force, and you can see how much tightness this has. One of the questions that I get all the time, you do get this forceps with the kit. However, if you have existing forceps that you've used for some of the other sectional matrix systems, like the V3 or some of them from other companies, they will work with this because this design is very, very similar. It's just enhanced for more better anatomical adaptation, and then also with these nice wedge designs. So this is what you get in the whole Wagotrix system, something that Kurt, I'm sure, will review the specials after this presentation. Okay, so let's take a look at another Class 2 restoration. I promise not only will I show a bulk fill method, as you saw with the 2 prior restorations, but in this particular case, you can see it was almost like a snake eye composite restoration. Notice this composite was not filled very well, so you can see over several years it's starting to wear down. Having a zirconium infused composite restoration, we're not going to see that. And look, this is what the trend is going towards, zirconium restorations. I'd say probably in the last 8 years, predominantly, I'd say 85% of my restorations now that are indirect are zirconia, and now we're finding that using the Wagofill, we're using zirconia infused composite restorations for our direct fill as well. If we look at the radiograph, we can see that the cavity has passed through the enamel to the next layer of the tooth, which is the dentin. So we're going to go ahead and prepare this. Again, we're not going to cross over to the other snake eye. We're going to try and maintain it here. We've broken the contact. We place our sectional matrix. What I recommend is now take a gold instrument and sort of burnish this to get a nice contact. You see the nice separation of the teeth. You see the wedge that adapts right into that V shape of the ring. And so we'll place our etch and then place our bonding agent of choice. And so in this case, we're going to use the C method, where we're just going to fill up, get the contact, and fill the proximal box, and then put another layer of the Wagofill. So there's no flowable in this. This is what it looks like. You can see we've placed that. And then we'll go ahead and use some more of the Wagofill and bulk it up. Cure this. Take our discs and polish. If there's any adjustment necessary in the occlusion, we'll go ahead and do that. And here we see the Wagofill, just one material, already opaque, being used for a Class 2 restoration with a nice contact and nice anatomical form. Now compare this with some of these other restorations that were done prior to this patient coming to our office. You can see the 2 different composite restorations. In this case, you can see they used the same composite restoration here, but they got a lousy contact. So using the Wagotrix and the Wagofill systems, we were able to get some really nice contours, and I feel confident that that material will last for a very long time because it's infused with the zirconia. Well, although the Wagofill is used for posterior restorations, I did try it in an area that was unaesthetic. And this was a patient that had veneers done several years ago, and they had some recession, and they were starting to get some micro leakage. So my goal was to open up these margins. Obviously, we recommended this patient getting some new veneers, but the patient did not want to invest in that right at this time. He didn't have the money to reinvest in new veneers. So we said, well, we'll do some repair and clean out these margins and place some zirconia infused composite restoration. So the first thing we did is anesthetize the patient. We retracted the area with cord. We prepared further, etched, silinated the porcelain restorations, placed bonding agent, and then used our Wagofill composite and polished. So again, we're going to use our phaser light with our Wagofill. And here we were able to repair this for the patient until he is ready to get veneers in the future. The reason I use the Wagofill is some composites are very translucent. And so if you use these translucent composites in an area like this or for a repair, then it shows the underlying tooth structure, or it doesn't blend in with porcelain. So using it in this method, the Wagofill actually worked very well to not only remove the decay, but have some nice aesthetic restorations. So if we compare the before and after, these are not new veneers. These are in fact the same veneers, but we clean this out and place the Wagofill. Well, a lot of questions that I guess get asked at trade shows is, well, you know, Wagofill is zirconia filled or infused. Why not use it for core buildups? And I say, absolutely. This is the best core material because of the zirconia. So here's a typical example of a patient that had gone and had a root canal done by her endodontist. We clean this out, and obviously here we're not worried about the context, so I'm just going to use a regular matrix band, or this is the greater curve matrix band, to just fill this up, and then I'm going to prep it so I don't have to use a sectional matrix. And in fact, I don't want to use a sectional matrix because it won't cover this area. So we'll do a bulk fill using the Wagofill with the phaser light, and we'll prepare that the same day. Notice this nice consistency. We'll go ahead and use the Expasil. There are a lot of other companies that have retraction paste. Parkel's got one. The Premier Dental's got another. So we'll go ahead and prep and retract, and then take a regular impression. My impression material of choice is the Panasil from Kettenbach. It works really well. I'll show you some cases using it. So here's the single unit crown restoration. And you can see we're able to do the core and the crown in a very efficient amount of time. Take the impression, and then a week or two later, cement the restoration. Well, what about multiple core restorations? Well, not only am I using the Wagofill for one or two cores in a mouth if they're endo-treated, but I also use it for teeth that may not be endo-treated, but have these large amalgam restorations that need to be removed. So here we can see the B1 shade that we've used for the core buildups using the Wagofill, and here we see the restorations. Okay. Well, what about Wagofill and pins? I know people thought pins were outdated, but again, I place a lot of implants, but if we're able to salvage a tooth, I would try to save it first if possible. So here we're going to clean this out further, but I'm going to place my pins. These are the fill hole pins. They come in two sizes. The red is the smaller size. So you get a drill, and these are self-ligating pins. So I place the pins, bend them inwards. These are pure titanium. And then use the Wagofill as a core buildup. Place the temporary, allow it to heal the gum tissue. And then when the patient came back, we removed the temporary, and look how nice this core restoration looks. This is not as traumatic to the tooth as placing a large post that can potentially cause a fracture. I found very little teeth fracturing when we're using pins as comparison to using a large post. If we take a look at this restoration, we've instructed the patient that we need to change this. This is an old macrofill type of composite. Notice it doesn't maintain its luster or shine, and if we were to take an Explorer, this would be very, very rough. All right, let's take a look at an example of a combination case, and then we'll wrap it up shortly to take some questions. This patient presented to the practice. He was terrified of going to the dentist for multiple years. So we can see several areas where he's got a lot of decay. Notice this area right here as well. So what we recommended, since we do IV sedation within our practice, is that we need to take out all the wisdom teeth. Tooth number 18 as well will have to be removed, as well as these premolars that are severely decayed. Again, as I mentioned earlier in the presentation, I always like to use cavity detection dye. And when I'm doing these combination cases, I'll do the restorative work first, and then I'll remove the teeth, since it's going to get messy if we go to extracting the teeth first and then trying to do the composites. So we'll keep cleaning these out until finally we'll start the filling. Here again, these cases, the Wagofill was used as well as the Wagotrix. We saw how they're delivered, so we'll talk about the specials of this whole pack. Here you can see the composite restorations. And notice, a zirconia-infused composite restoration may not be as translucent, but in the posterior portion of the mouth, I don't want it to be translucent. I want to see where this composite is so that when this patient comes back for oral hygiene visits, we can see exactly where the restoration is, and it's maintained its strength and shine and luster. So once the restorative has been done, I'll go ahead and extract these teeth. These are the separators from GoldenDent. Some of you have seen my presentations on strictly extractions. So we remove all these teeth. Using the physics forceps, we're using a modified class 1 lever to atraumatically extract these teeth. So you can see we took out both roots. We'll clean this out with a curette and then use a bone substitute. This is Osteogen, also available through GoldenDent. It's a resorbable calcium apatite synthetic graft that's maintained within bovine Achilles tendon base, and it comes in a variety of sizes. So for the premolar, we went with the slim, as you can see. So we'll compact this with the bone packer, also available from GoldenDent. And so we'll continue around the arch. Notice again, we're going to keep cleaning these out. Start with the restorative, use our Wagotrix and Wagofill, and then from there we can continue with the extraction. So we take out the premolar and the wisdom tooth. Again, notice we're using the physics forceps as a modified class 1 lever. And this we were able to get out in one piece. Again, we'll use the slim Osteogen plug. And then for the areas of the wisdom teeth, this is a material. It's called BioViva, also available through GoldenDent. And essentially, it's a cellulose-based bacteriostatic hemostatic gauze. So this resorbs. You don't have to remove it. It stops bleeding immediately. And so we're obviously not going to be placing graft material in an area of a wisdom tooth, but this will help control the bleeding and prevent dry socket, as you can see here. So this is the Osteogen in the premolar, and in this area we have the BioViva. We continue in the other arch. This is the lower arch. Notice we're going to start with the restorative, keep cleaning these out until we get the decay out. And if we're using the phaser gun, we'll do it as a bulk fill. If we're going to do the traditional method with a regular composite gun, we'll base it up with a flowable composite and then follow up with the Wagofill. At that point, we'll remove the teeth that need to be extracted. The wedge is another instrument that I created for GoldenDent, and it works sort of like a luxator and an elevator in one. So you don't have the curvature that much like an elevator. You're actually able to take this down the long axis of the tooth in the PDL, and because it's got an elevator style handle, you can put quite a bit of force to get some micro movement and then follow up with the physics forcep. Obviously with wisdom teeth, we're going to have to section those. This is the osseous cleaning and shaping and sectioning kit from GoldenDent. So we're going to use this burr to section or trench around those and then get these separators in and luxate the teeth out. So you can see we got that tooth out. Place the BioViva in the wisdom tooth area, and then in the tooth number 18 area, we can place an Osteogen plug. We finally follow up on the lower right quadrant. So this is all 4 quadrants were done at one time, the restorations as well as the extractions and grafting. So again, we're going to start with the restorative. We're going to extract this tooth. Here we're using the wedge, and then we went ahead and root canaled cord this with the Wagofill and prepared for the crown. We're not obviously going to take the impression on day 1. We'll take it 2 weeks later, once the gum tissue is healed. And here you can see the radial opacity of the Wagofill restorations. So we took out 1, 2, 3, 4, 5, 6, 7 teeth, and we did about 10 restorations and 1 root canal. So when the patient returned several months later, we scanned this patient. Notice how the Wagofill maintains its strength, luster, and shine. We scan this patient and we plan for future implants using surgical guides. So here you can see the areas that we've grafted. Let me show one more case and we'll wrap it up. Patient dissatisfied with her smile. So we're going to use short-term orthodontics. You can't see them, but several teeth have decay, and then some of these other teeth will seal. This is a cavity. You see the cavities in the lower arch. So being able to offer orthodontics in your practice allows you to do a lot of restorative, because we want the restorative completed before we do the orthodontics. So here you can see the treatment plan. Again, we use the Wagofill. So here you see where we did the Wagofill. These are just sealants in the premolar areas. And then obviously we extracted the 2 wisdom teeth. Here we use the wedge. Obviously these are too far back to use the physics forceps, so we pretty much rule these out just using the wedge. Great instrument. I highly recommend. If they have a promotion at the end of the seminar, take advantage of it. Not only is it a great pre-step to the physics forceps, in certain cases you can use these to get the teeth out as well. Here you can see the cavities on the molars. We use the Wagofill shade A1 on those, and then here you can see where we use the sealants. The sealants are from UltraDent, UltraSeal. This is the orthodontics that we did, and this is after orthodontics. I'll quickly show you the arch form. This is before whitening, and this is after whitening. So if we look at her before and after, we were able to provide a great service to this patient. These are some of the more complicated type of extractions that we teach at the Amplified training course that Kurt will be talking about, where we illustrate to you how to section teeth, remove these roots, and graft. So this is the osteogen. Here's the other quadrant on this patient where we section. So we teach all our doctors how to do this at the University of Detroit Mercy, where you get a chance to work on live patients. So we have a morning session of didactics, and then we'll go ahead and do this on the clinic floor on live patients. So great opportunity for you to be able to provide not only restorations, but extractions and grafting for your patients. So here you can see this patient. We set the foundation for implants, and also one on the top. You know, having the ability to provide all these services under one roof for your patients really allows you to be a very comprehensive dentist. And quite honestly, if it's something that you can handle, the patients don't want to go to multiple offices. They want to stay within your practice. So here we did 5 implants, 4 on the lower arch and 1 on the upper arch. These are all the radiographs, and we talk about this quite extensively in some of our other webinars. Here we can see some of the composites we did for this patient. We took the impressions using Kettenbach's Panasil as well as their bite registration, a great material to use not only for crown and bridge, but also for implant restorations. And here you can see the workup from the laboratory and the final restoration, and then the 4 final restorations in the lower arch. Again, I welcome you to come to the Amplified training courses. Not only are we teaching extraction and grafting, but also multiple extractions and immediate dentures and the leveling that we do and the grafting that we do. But also I'm the Chief Clinical Officer for Ascend Dental Academy, and we instruct dentists the next level after extraction and grafting, which is implant placement. I want to thank you for giving me this opportunity to speak, Dr. Levine, and let's see if we have some questions.
Well, I wanted to turn it over to Kurt for a couple of minutes. As I mentioned at the beginning of the webinar, we're very happy to have Kurt Lawler from GoldenDent here. Kurt's always been very kind to present some special offers as well as to talk about the educational opportunities that they have. So I'm going to turn the screen over to him and let him give us a brief presentation, and then we'll kick it back for a Q&A.
That sounds great. Thank you.
All right, I appreciate it, Lauren. I hope everybody enjoyed the presentation this evening. We have done a lot of presentations in the past on extractions, grafting, in preparation for implants, and I hope everybody enjoyed a little bit of a different subject this evening, focusing more on the restorations, and I hope everybody enjoyed it that's joined our past webinars. So let's go over a couple slides here before we get into the Q&A portion of the presentation this evening. The Wagotrix is our new sectional matrix system. As you can see, the pricing is very competitive on our kit. It's actually a lot different than a lot of other sectional matrix systems on the market. With the promotional offer that I'll provide here in a moment for the 15% discount coupon code, this entire kit is only $125. So our sectional matrix system is pretty much the price of other competitors' rings. One ring is pretty much the price of our Wagotrix kit. And so you get 35 of the rings with our system, and then you get 25 of each size of the wedges, and then 25 of each of the anatomical matrix bands. So that's something to take a look at if you haven't joined one of our webinars recently or haven't been to our website in a little while. If you're currently using the physics forceps or some of our other products, we do have this new Wagotrix system that we've had a lot of really positive feedback on over the last 4 or 5 months since we've been offering this kit to our customers. A lot of doctors that are using our ring, they'll say, maybe they like it for the ability to be able to modify the ring. We're finding more and more uses each day of our ring as people use it more and more in their practices. Say you want to cut one of the tines off, or if you have a specific case where maybe you want to modify the ring, this system provides you that opportunity because you don't really care if you damage the ring because you're going to toss it after its use. Also, we have a lot of doctors that like to have our ring in their office where maybe the staff accidentally tosses the ring, or you don't have to want to worry about how many uses you've used the ring for. Are you on the 49th use, the 50th use, the 100th use? You really don't know when you're going to lose that perfect separation that you're expecting from your ring. And also some people just say, look, I mean, the ring looks gross from getting composite on it. The ring I have shown here in the picture was from one of our dentists that's using our system, and this was a ring that was only actually 10 days old, and so it just didn't look aesthetically pleasing, and they were almost a little embarrassed to use it in the patient's mouth looking like that. So it's not so much the fact that the ring is cost effective. The real big benefit is going to be the perfect separation force each and every time, which is going to give you those tight contacts that you need from a sectional matrix system. So Wagofill, we went over this in great detail. I'll just, excuse me, go over this just real quickly. It's 40% zirconia infused. It's radiopaque, low wear, minimal shrinkage, and has increased strength, as was demonstrated by Dr. Nazarian this evening. I showed just a couple of our instruments. We do have, we call them Wagoform. There are a couple composite instruments you'll find on our website under the restorative section. If you are looking for some new composite instruments, we've kept it simple to only 4 instruments. If you want to take a look at those with a promotional offer, it may be something if you want to get some new instruments for your practice. We do have those available also. I'll mention the code here, and before I go over just a couple more slides, as a promotional offer or for joining the webinar this evening, we would like to offer a 15% discount code, which is a ring 15, so it's just RING 15. And you can use that promotional code on our website, which is golden-dent.com, or by giving us a call in the office at 877-987-2284. This pricing is actually even better than a lot of the trade show pricing we offer or other discounts we do. So we do these deals for, if you joined our past webinars in the past, you know we do them for 24 hours. And so the 15% off discount, if you find anything on our website that's interesting, or if you wanted to try our new composite material, you have until tomorrow, the 6th, to take advantage of that promotional offer. The physics forceps, I know a lot of doctors that join our webinars join over and over again. I know a lot of people are already using the physics forceps, and that wasn't the focus this evening, but I still just wanted to mention it. This is still, one of our more popular products we offer at GoldenDent. If anybody is looking at wanting to try an extraction system, the promotional offer on the physics forceps is a good opportunity to receive some savings this evening, and you always have our 90-day trial on the product, which is something we've offered for the last 12 years. If you're not happy with the product for any reason, you're never stuck with it, allows you to get it in your hands and try it for 3 months. This is our standard series. This is the most popular set that doctors would start out with. This is going to do second molar to second molar. And we also have one other set that we didn't show this evening based on the topic. This is our molar series. This is going to go a little bit further back into the mouth and allow you to access hard to reach third molar, hard to reach second molars and erupted third molars. If you can get access to any type of tooth structure, this molar series will allow you to get further back into the mouth, but you do lose a little bit of your leverage, where the standard series is going to be a better lever instrument and it's a little bit easier to use than this set. This is the wedge. We do have this available on our website. As Dr. Nazarian mentioned, this is a perfect pre-step to the atraumatic extraction process. This is a newer instrument for us, so if we have some doctors on the line this evening or on the webinar this evening that have been using the physics forceps for a number of years, this is a great instrument to maybe take a look at to use prior to the physics forceps, just to start to elevate the tooth a little bit prior to using the physics forceps instruments. Separators, this is another instrument that could be used. You can learn more about those on our website. I'm just mentioning them quickly because a lot of doctors ask us, do we need to elevate in advance with the physics forceps, or what do I use? And this is another alternative to just going straight to the physics forceps. Osteogen plugs, again, this is not a grafting webinar this evening, but this is a super popular product for us. I just wanted to mention it. If anybody is already using the osteogen plugs or wanted to stock up on the plugs, the promotional offer would obviously, of course, be available for the osteogen plugs also. And if you're using our graft material, again, another opportunity to save a few dollars on our graft material. If you haven't used our graft material in the past, we'd obviously love to have your business of the allograft. It's a good product at a fair price, and it's something to take a look at if you're interested. BioViva, this is a great alternative to gel foam. As Dr. Nazarian showed it this evening, he likes to use it in a more third molar area or a site where you're not grafting, or if you have a patient that you need to control the bleeding, the BioViva is a good product to have in your office. Lastly, I'll just mention our Amplify Dental training programs. These are the hands-on programs we do here in Detroit, Michigan. These are just some class photos of our AMP1 extraction course. We usually will max it out around 25 doctors or so. We try not to get too many more than that, so we have a good instructor to student ratio. This is some of the classroom hands-on portion that we do prior to the live patient portion, where you'll see we do modeling work. We use all the materials, so you're familiar with them before you step onto the clinic floor. This is Dr. Nazarian doing one of the lectures where we go over a lot of really great comprehensive step-by-step rapid photography photos and going through the techniques so everybody's comfortable on day 2, once you step on the floor, working on the live patients. Excuse me. Our next program is coming up on March 22nd, 23rd. I think as of this morning, we had about 3 seats left. Again, this program for AMP2, which is our grafting 2-day program, we try not to take more than about 15 doctors for this course. So I think we had about 12 or 13 doctors registered when I looked this morning. So if you are interested, that's coming up here in a few weeks. Love to have you in Detroit. We do have a couple seats open still. This is the clinic floor at the University of Detroit Mercy Dental School. Very comfortable environment. You have your own operatory. There's always plenty of patients here in Detroit needing free dental care, and it's a great learning experience. So this is Dr. Nazarian doing a demonstration of a certain technique prior to breaking out into your own operatories. We usually do a couple demonstration patients to make sure everybody's comfortable with the procedures that we learned in the classroom. And I guess that's it. So I'll leave this up on the screen. Again, ring 15 if you want to save 15% on anything we discussed this evening, or anything on our website for that matter, or educational programs. That's the promotional code. And I will turn it back to Lauren for the Q&A session.
Thanks, Kurt. Okay, we got about 20 minutes. All right, you ready to roll here?
I'm ready.
Okay, in the interest of trying to get to as much stuff as possible, some of these questions may have a couple of parts to them. Like, I'm going to try to combine a few of them so that we can get as much content in here as we can. And I know that you probably touched on some of this during the webinar, but some people came a little bit later, or weren't 100% clear. So I realize some of this may be a bit of a rehash. The Wagofill, what type of composite is it? Is it a hybrid? What's the percentage of zirconia, and does it make it hard to shape?
Yeah, so the Wagofill is a hybrid composite, and it's 40% infused with zirconia. However, there are also silicate particles, so you have a combination of the two. What this allows you to do is have a composite that is made for strength. As we discussed in the presentation, we're starting to use more and more zirconia in our practices for indirect restorations. So why not use zirconia infused composite for our direct restorations? The positives about it are many. Number one, it's stronger. Number two, it's radiopaque. Number three, you'll have less shrinkage because there's more particles in there. That's usually the resin that's is shrinking more than the particles. And the list goes on and on.
Got it. A couple of questions here about the rings. Let me just see if I can try to combine as well. Okay, I like the idea of the rings, but can I use the ring forceps I already have from PaleoDent?
Yes, you can.
Okay, and can the rings be sterilized?
So the rings should be used for individual use. However, the material is such that if you do want to put them through the sterilization, they will not melt. They're not intended for that. However, I know some dentists are trying to save on I don't know what because it's so inexpensive to get these disposable rings. But yes, they can be sterilized. Now, if they are, I don't know, I wouldn't recommend it being used more than once or twice. That's about it after sterilization.
Okay.
Because they're not intended for that. It's like taking any product that you buy and say, can you do this for it? If it's not, that's not how it was meant to be used.
Okay. You showed the wedge that you used. Do you always do that before using the physics forceps, or do you pick and choose which cases you use that for?
Now I've been using it for all the cases. Since I'm the guy who created it for GoldenDent, I found, in some cases, it would take a little longer to use the physics forceps than others. So I said, what a great pre-step to use. And in some cases, if it comes out faster, great. And in others, when it doesn't with just the physics forceps, then you can use the wedge. I say use it every time. And if you get some mobility, then go straight to the forcep then.
Okay. Couple questions. Can you recommend which polishing and finishing burrs you like to use?
With the Wagofill, if you're just using red diamond burrs and yellow finishing burrs, you really don't have to sit there and keep polishing. So I'm not using like polishing cups or anything like that so much. I will use the discs if I have to take some extra flash off around the contour of the teeth. But I found with the Wagofill, really just going to a fine diamond, like red first for adjusting and then a yellow diamond, you really don't have to sit there and try to super polish this composite restoration.
The matrix bend, the Wagotrix matrix bends, how do they compare to others like Palodent or Triodent?
So Triodent had the V3 ring, and the design of this is very similar, but they've increased the V just a little bit more to get a little bit more separation when you're trying to get the contacts. I used the V3 from Triodent for many, many years, but I found over time that the metal would weaken, and so you weren't getting that separation consistently every time. So what I would do is sit there and try to burnish a little bit more and contour, and then after you went through all that, you would floss the restoration, and you didn't have the greatest snap. So I think it's ingenious that they came out with a system that is like a unidose system that can be used, and you have a new one every time. And Kurt brought up a great example. I found over time that, you know, as you use these rings over and over, like a Triodent or a Palodent or a lot of the other ones that are out there, they're great systems. But yeah, after a while, they start discoloring, and patients are looking at this going, what is this? It's almost like rubber dam clamps, right? You sterilize them so many times, even that metal starts to turn color, and it doesn't look like it's the most ideal thing to put in somebody's mouth in a dental office.
Mm-hmm. Yeah. Speaking of Kurt, there's a couple of questions here that I think you're probably best suited to answer. One of the questions was at the live patient course, that Dr. Nazarian be there to teach them. And for our Canadian listeners, can they attend the courses and work on live patients as well?
All right. Yeah, sure, no problem. Yes, we've had a lot of doctors join us from Canada, so that's as long as you have obviously a valid Canadian license or license in any of the U.S. states, you're able to attend our course and work on the live patients, because we do it at the university, which is a teaching facility. So yeah, absolutely. I would say every course we probably have 5 or 6 dentists join us from Canada. I don't know if it's just because we're not too far away here in Detroit. I'm not sure, but yes, absolutely. And the other question is, yeah, absolutely. Dr. Nazarian's our lead instructor for the Amplify programs. He does the lecturing, the demo, and yeah, he's our go-to guy for the program. So he absolutely will be available and be at all of the Amplify programs.
Great. Okay. A couple questions coming in here are about rubber dams versus due to the fact that you didn't show any rubber dams in most of your slides. Are you not using rubber dams?
Yeah, I'm finding we'll use like cotton roll isolation, or my assistant's using the IsoLite, or we'll use high volume suction. And, you know, we're finding that we're not having issues. In my practice, I'm using a rubber dam when I'm doing endo. I'm not using it routinely for composite restorations, unless this patient is just very difficult to maintain the dryness in that field. Otherwise, no, I'm not using it. But the system can be used whether you're using a rubber dam or not, like any other sectional matrix system. It's up to you if you like to use a rubber dam or not.
Okay. Couple of questions. I want to see if I can combine these. A couple of questions on warming the composite. Do you always warm it? What are the advantages? GoldenDent has the gun, you know, and the warmer in one. Have you used that device, and how does that work? Sorry,
right.
A lot
so
of stuff
I
there.
have 3 operatories that I work out of, and I only have 1 gun at the moment. So in those rooms, if I'm bouncing from one room to the other, sometimes I use the gun and sometimes I don't. I wanted to illustrate tonight that if you can use the gun, I would recommend it, because it enhances the composite for molding it and placing it into the cavity, and it adapts. There's a lot of advantages to using the heat. However, you can use a traditional composite gum And so if I find that I'm going into another room to do one composite compared to 4 composites in the other operatory, I may just use the gun. So I would definitely recommend, trying it out and seeing the feel of it if you like it. But yeah, I would say ideally my goal would be to use the gun to just do a bulk fill every time.
Okay. With the Wagotrix zirconia, are any concerns about excessive wear against the opposing teeth?
No, it's not that much zirconia that we're worried that it's going to wear the opposing dentition like you would see with a full zirconia crown. A full zirconia crown, remember, is a puck of that stuff that's condensed very, very hard. So it's a little bit different in nature. What they've done essentially is taken composite, a microhybrid, and said, okay, we have silicate particles, but let's infuse it with zirconia somewhat as well and make it more radiopaque, stronger, and a little bit more packable.
Got it. Okay, so a couple of surgical questions here. With the physics forceps, are you typically sectioning lower molars, or is that not always necessary?
I would say probably 9 out of 10, I'm sectioning the lower molars just because the anatomy of the lower molars, unless somebody has like a conical root structure, then obviously we're not going to section it. We're going to go straight to the physics forceps. But if it's a bifurcated root, then almost always I'm going to section it and then treat each individual root as if it were an individual tooth, place the forceps, and pretty much leverage that tooth out of there.
Okay. For the Wagofill, what are the long-term results with it? I mean, I know you've been using it for some time, but how do they look months, years later, and how does that compare to other ones that you've used in the past?
So I can tell you that I've had the availability of using it for over 2 years now, and I could tell you with this formulation, I have seen patients, I've documented to look at it and really rate it, and I haven't seen wear like I've seen some of the composites of yesteryear. Also, what are the two main, areas where composite goes bad? One is the wear, and the other is micro leakage. So I think if you heat the composite, you don't see as much micro leakage. If you have a composite that doesn't have as much shrinkage because it's got more filled particles, you don't see micro leakage. And then if you have something that's more filled, you also don't have increased wear. So for those areas of where composites go bad, like we saw in some of the photos, the Wagofill is my go-to composite for posterior restorations.
Okay. We had a couple comments here from people who just love the physics forceps. It's really changed their practice. It's changed their lives. And, so thanks to you and thanks to Kurt and GoldenDent, because obviously those are a very popular product. A couple questions here about the plugs, the Osteogen plugs. Do you typically need a membrane with them? What's in the plug? And can you explain again how you cut them up and place them?
Sure. So the Osteogen plug has the synthetic material, which is the Osteogen, which is the substitute for the bone, and it's maintained in a bovine Achilles tendon. So if you were to take a collagen plug and if you were to take the Osteogen plug and squeeze them in your hand, the collar plug will just sort of like squish very easily, and once you wet it in the mouth, it is very flimsy. In other words, for one socket, you end up needing 2. The Osteogen plug, what you'll find is the consistency, it's a little more dense. And so when you put it into a socket, you're compressing it. I don't want to say you're condensing it like an amalgam because you don't want to do that, but when you're compressing it into the socket, it takes several seconds for it to get wet and then adapt into that socket. So you're putting a little bit more force to condense it. It's not flimsy like a collar plug, and you do not need primary closure. So if you're using particulate graft or putty graft, you always have to cover that with some type of a membrane. With the Osteogen plug, you do not need the primary closure. However, you do have to suture over it so it doesn't come out. And you don't want to just put one suture. You want to put several sutures so that you don't lose the graft, obviously. But primary closure is not a necessity.
Okay, well, I'm sure we get to as many questions as we can here. Speaking about grafts, what allograft do you prefer? Are you using a cortical cancellous mix or what else?
Yeah, I'm using a cortical cancellous mix. GoldenDent has Golden Os, and they have it in a particulate graft, and they also have it in a putty. But the putty can be either as just the putty itself or with cortical chips for more consistency if somebody prefers that.
Okay. Any problems getting patients to accept grafting? How do you normally approach that with them?
Usually if it's an area where they want to replace the tooth with an implant, getting their case acceptance on that is very high, because when I present to them, I'll tell them first and educate them about the problem, and I'll educate them about the consequences if the problems aren't addressed, and then I talk to them about the solution. A lot of times dentists get a little antsy and they jump right to the solution without creating the need for that solution and what will happen if they don't pursue an implant. That the bone will resorb because it's not being stimulated, the teeth may shift, or the opposing arch tooth may hyper-erupt. So it's a whole process, and we go over that actually at the Amplify course. I'll give the doctors several examples of what I use in my practice to be able to get a high acceptance rate, not only for extraction and grafting, but also for implant placement as well.
Okay. Any experience or concerns about sensitivity, post-placement sensitivity with the Wagofill?
No, I found that there's less sensitivity. I'm still using the OptiBond. I was using the OptiBond Solo Plus, and now I've gone to the OptiBond Universal. So I definitely recommend going with a bonding agent that you've been pleased with and that you've never had issues with. And now if you're enhancing that with the Wagofill, I'll tell you, you'll find much less sensitivity or no sensitivity. I don't think I've had sensitivity with composites in a very, very long time. And if it's deep, if I have to use a resin modified glass ionomer, if it's like right over the pulp, then I'll do that before I do the bulk fill of the Wagofill.
Okay. Getting back to the Osteogen plug, what was the black suture? What material was that you were using?
That was silk. Silk is very inexpensive to use, and I like the fact that they have to come back 7 to 10 days later for me to remove it so that I can, view the area, look at it post-operatively, and make sure that everything is healing nicely. So a routine in my office is see the patient 7 to 10 days after we've done the extract and graft, and then see them about a month and a half later to make sure everything is healing well. Again, I don't want to lose any graft because I'm the guy who's placing the implant, so I want to make sure that foundation is built properly.
Okay. Any recommendations on curing lights?
The Optilux or the Demetron from Kerr has been a great one over the years. I'm testing one right now for GoldenDent that looks very promising. I don't know if that's available yet. I would say if you're going with a curing light, have one that you can set in different phases, and then also look to see that it has a pulse as well. We found that pulse curing lights work very, very well compared to just one consistent type of light.
Okay. With the Wagofill, are you ever putting like a final seal with some unfilled resin over the finished composite?
So in the past, when I was using other types of composites, I would use OptiGuard, which is a product from Kerr, to seal the restoration. I'm finding with this, there's really no need to seal it because, again, it's a microhybrid that's filled with zirconia. Zirconia is something that maintains its luster and shine and strength. I mean, think of a Bruxier crown I mean, you can't break that. So if you have a composite material that's heavily filled with this, you're going to find that it's not going to break down. If you're used to sealing your direct composite restorations, I don't see it being a problem, but I don't see there being a huge need. And again, I've seen these restorations not only a month later, but up to a little over 2 years later, and they're maintaining their strength and they're not wearing, and the marginal integrity is still very good.
Great. Well, we're at the bottom of the hour. Ara, I want to thank you so much for sharing your wisdom and expertise with us. I've had the pleasure of listening to you speak on at least a dozen webinars, if not more, over the last couple of years. They're always entertaining. Not much filler here, no pun intended. It's chock full of content, and we really appreciate your time. So anything you'd like to say before we wrap things up?
No, I'd say, as Kurt mentioned, if you want, try the material out, take advantage of the savings, because they do have that return policy. If for some reason you're not happy with a product, I know they've found, and I found, because I refer a lot of people to their courses, that they're always happy with what we have to present. But definitely try composite out. It's very inexpensive, as well as the rings. And we'd love to get feedback from those doctors and photos. We're building a library of a lot of these doctors that are sending us stuff of how well this material is working. So I'd love to see your cases too.
Great. Well, speaking of Kurt, we want to thank him as well for joining us this evening and for letting us know, what opportunities they have out there. I think that's a fantastic special. They mean what they say when they say 24 hours. So don't call them next week and say, hey, I'm ready for that Ring 15 code. It's not going to work. So, but because of their return policy, I highly recommend you take advantage. It's a very generous offer. And Kurt, your just ongoing commitment to dental education, the fact that, not only do you have these great products, but you present so many educational opportunities for people to learn how to use things properly, I think is really special. So we want to thank you and let you have the final word on the webinar tonight.
Thank you. I appreciate it. And I thank everybody for joining us this evening, and look for a future invite, maybe in the next month or month and a half, for our next webinar. Thanks, everybody.
Thank you,
Kurt.
And
have a good night.
Yep. Yeah, as Kurt mentioned, we do these on a regular basis, so stay tuned to your inbox. These things usually go out on a pretty regular time frame, and we look forward to seeing all of you on future webinars. We thank you for joining us this evening. We know your time is valuable. Hopefully you got a lot out of this, and we will see you all on future webinars. Good night, everyone.